All right, so welcome back. This is the Heart Physiology Part 2. We just finished with this EKG, ECG, and explained the different parts of the tracing. Here are some figures from your book that are very helpful in understanding the ECG tracing and the heart's activities and how they are coordinated. The top figure shows the P wave, where atrial depolarization is initiated by the SA node. The middle picture shows the PR segment, where atrial depolarization is complete and the impulse is delayed at the AV node. This allows for the atria to contract before the ventricles contract. The bottom figure shows ventricular depolarization, beginning in the septum down through the apex, causing the QRS complex. Atrial repolarization is also occurring during this time, and you can see that as shown in this red part of the atria. The fourth step is the ST interval, where the ventricle depolarization is complete. The fifth step shows the ventricle repolarization beginning at the apex, which causes this T wave. And then lastly, the flat area after the T wave is when ventricular repolarization is complete. All right, I'd like you to watch this video. It's a short video, about 3.5 minutes long. Okay, so that is a really good video to watch and to understand all the different parts of the ECG. The following slides show different ECG tracings. Here we see a normal tracing. This is called a sinus rhythm. We can see consistent P waves, a consistent P wave here, followed by the QRS intervals, and then the T wave. Oops, sorry. So we have the P, is this little one, this is a P, this is a P, this is a P. Then we have QRS and then T. Okay, so P, QRS, I'm sorry. We have P, QRS, T. P, QRS, T. The waves are very regular, and we can count the heart rate by looking at how many beats occur in 6 seconds and multiply by 10. This is a 6-second tracing, so there are 1, 2, 3, 4, 5, 6, 7, 8 peaks. We multiply that by 10. 8 times 10 is 80 beats per minute. So 80 beats per minute, that's a normal heart rate. Defects in the intrinsic conduction system can cause a number of problems, including arrhythmias or irregular heart rhythms. Other problems include uncoordinated atrial and ventricular contractions. Fibrillation is the rapid, irregular contraction of the heart. During periods of fibrillation, the heart becomes useless for pumping blood, causing the circulation to stop and may result in brain death. Treatment for fibrillation is defibrillation, which interrupts the chaotic twitching, giving the heart a clean slate to start regular, normal depolarizations. Excuse me. Here we see what ventricular fibrillation looks like on an ECG. The electrical activity is disorganized. We see this in acute heart attacks and after an electrical shock. Another problem in the cardiac conduction system is when the SA node is defective. This may cause an ectopic focus, which is an abnormal pacemaker that takes over the heart's pacing. When the AV node takes over, it sets a junctional rhythm at 40 to 60 beats per minute. Extrasystole or premature contraction occurs when the ectopic focus of a small region of the heart triggers the impulse before the SA node can, causing a delay in the next impulse. So remember, the SA node is considered the pacemaker of the heart because its depolarization should occur the quickest, and it causes the rest of the extrinsic conduction system to follow suit. However, when the SA node is broken, it's not working, it's slow, whatever reason, then other things can take over, the other pacemaker cells. The heart has a longer time to fill, so the next contraction is felt as a thud because the larger volume of blood is being pushed out. This can be caused from excessive caffeine or nicotine. This slide shows the ECG of a junctional rhythm when the SA node is non-functional. So we don't see the P wave, it's very flat, but we still have the QRS and then the T wave. So when you see a tracing like this, you know the SA node is non-functional. Another type of problem occurs when the AV node is blocked. So imagine we start with the SA node. It's going to try to go to the AV node, yet it can't go through there. In this case, an impulse does not reach the ventricles, and this is called a heart block. The ventricles beat in their own intrinsic rate, and it is too slow to maintain adequate circulation. In this circumstance, patients are treated with an artificial pacemaker, which recouples the atria and the ventricles so that there are coordinated contractions. This tracing is of a second-degree heart block. In this case, we see more P waves than QRS waves. So here we see, we start here, we see P, P, Q, R, S, T. P, P, Q, R, S, T. So there's obviously a block between the atria and the ventricles, so they're not able to coordinate properly. All right, we're going to watch a quick video on atrial fibrillation. Okay, so one thing that, excuse me, one thing that I want you to take away from this is that with atrial fibrillation, the biggest thing that we worry about as practitioners or as nurses is going to be that a clot is going to form and then it'll either become a stroke or it can become an embolus, like a pulmonary emboli. So patients are typically put on some sort of blood thinner to prevent these clots from forming. So, and remember, the clots are forming because there is a pooling of this blood in the atria. So they're just kind of, it's not getting contracted because it doesn't have the SA node interaction and causing the contraction in the pacemaker cells. Okay, I'm going to stop here and then we will pick up with part 3.